So good afternoon to our TB Think Tank members, and a very warm welcome to this crucial and much anticipated discussion. I'm Priya Subrahyan from the Aurum Institute, and I have the privilege of leading the TB Think Tank Secretariat. Today we are honored to be joined by two esteemed leaders in our field, Professor Norbert Ndjeka, our TB Think Tank Chair and the Chief Director of the TB Control Program at the National Department of Health, and Professor Abdullah, our Co-Chair, who is also the Director of the Office of AIDS and TB Research at SAMRC. They will both guide us through what promises to be a deeply important conversation. We find ourselves at a challenging moment following the announcement by the US government to realign its priorities and terminate critical aid to South Africa and other nations in TB, HIV, and the public health sectors. This decision has sent ripples through our community, leaving many of us concerned about the future of our programs, our patients, and our communities. For some time, the weight of this news has left voices muted, but today we gathered to break the silence, to reflect, and to strategize. In preparation for this discussion, we invited you to submit your questions and insights, and we are deeply grateful for the thoughtful engagement and all the reflections that we've received. To ensure a focused and meaningful conversation, we have carefully consolidated your questions into key thematic areas, which our panelists will address during today's session. We are here not just to share information, but to collectively and hopefully chart a path forward. Your voices have shaped today's agenda, and we look forward to a robust and solution-focused dialogue. Before we proceed, let me extend my deepest gratitude to both professors for their leadership during this uncertain time. Let's lean into this discussion with honesty, resilience, and a shared commitment to finding solutions. We will begin with the opening remarks from Prof. Ndjeka, who will set the stage for the dialogue and deliver a 20-minute presentation on South Africa's newly launched NTB plan, which is really a critical roadmap for our path forward in these uncertain times. After the presentation, we will then hear from Prof. Abdullah, who will share his insights and reflections on the implications of the US government funding termination, not just for our programs, but for the communities we serve. More importantly, he'll guide us on how we maintain momentum, safeguard our sanity, and stay focused on our core purpose during this transition. This is not just a briefing, it is a call to solidarity and action. So let's use this time to strengthen our resolve and redefine our strategies. Without further delay, it is my honor to invite Prof. Ndjeka, our TB Think Tank Chair, to open today's discussion. Prof. Ndjeka, the floor is yours.
Thank you so much, Priya. Thank you, Chair, for allowing me to speak. So what I'll do now, I will I'll share my presentation. So today we're going to talk about the campaign, the NTB campaign, and the executive orders, the impact of executive orders on the services. I'm sure that many people on the call are wondering, is this going to happen? We have all these challenges. Is this going to happen and all that? But let's go through the campaign presentation, and then we will discuss further after the next talk from Prof. Abdullah. But the campaign is long overdue. This is what we undertook to do. The Deputy President of the Republic launched this on the 24th March. And I wish to just give you a few ideas. We're missing a lot of TB people in South Africa. It is a reality. We know that. This just to remind us in terms of the missing people, despite the fact that the incidence is coming down, we still miss, as you can see here, we have.
Sorry, Prof. Sorry, Prof, to interrupt. Yeah, can you put it on a presentation mode?
Oh, I see a presentation mode here. Let me see.
Switch, yeah.
Wait, maybe I should stop sharing and share again.
Okay, perhaps that can help.
Or do you want to, wait, let's see. Is it okay now?
It's not showing yet.
Oh. Good. Let me share. I don't see my, can you show my slide from your side?
Okay.
Good. So the aim of the campaign is to test 5 million people in the year, during this year, and move then 5 million every year. We're hoping to then diagnose 250,000 TB cases a year, which represent 20% increase in terms of case finding. And then modeling has shown that we can then get 29% reduction in incidence and 41% reduction in mortality by 2035. So this is data that doesn't really include your vaccines, if we get effective vaccine and all that, but you can see is a big number. Can you move? Can you move next slide, please? Okay, I don't see that. Okay. So this was launched on the 24th March, like I explained. So we developing a multi-channel social and behavioral change campaign, communication campaign targeting the public. A number of materials have been developed. Some have been in the public domain. I'm not sure how many people have seen Minister speaking on national television about TB. There have been more TB adverts on TV than we've ever had before. We're making sure that the NHLS gets capacity to do this and also get the funds to do this and provide results. So this is happening. I know that people on the call will say, but you guys pay NHLS very late, but that has nothing to do with the executive orders. That there are provinces in South Africa that pay late to NHLS. Has been there, but they end up paying and all that. So the funding here, I'm talking about domestic funding plus global funds funding. There's no USG funding for testing here. It is domestic funds and global funds that is been budgeted there. And we want to address socio-economic determinants of TB through this campaign. And there is a M&E framework that is being put in place. Can we move to the next slide, please? So the next slide just gives the key issues, what we want to do: raise awareness, encourage testing. You want to find TB, to end TB. Stigma is a big problem. We're hoping that will also be reduced. And then all stakeholders get involved and we collaborate. We're working very closely with SANAC on this. Can you move to the next slide? They've been very good support from South African National AIDS Council. Testing should focus on patients who are more at risk. I think our policies are really very clear around this. We started the targeted universal TB testing. This is going very well, but we still need more effort from everyone, particularly people living with HIV. We are not sure, we do not have evidence that all of them get tested once a year, regardless of symptoms. Move to the next slide, please. So the testing is moving on. We've diversified the machines. We have your gene expert still in place. We got BD, we have Roche. And the next slide provides the tests to be done per province. And here you can see we done 2.7 million, quarter one 2024 to quarter three 2.1. I think at the end of the year we reached 2.9 million, and that's how the increases, the figures are looking like. Free State need to do more tests. But if you look at our bigger provinces, KwaZulu-Natal, we're looking at 55% increase from 2023. Limpopo, we want more, 160%. But in a nutshell, this is where we are and what we want to do. So it is possible from my own understanding, it is very possible to do 5 million more, especially if we consider the fact that if you look at all the wastage and all these tests that were not, conclusive, and all the your duplicate, how do you call this thing, the rejection and all that, we know that the total of samples submitted were like 4.4 million. So if we just become more efficient, more we cut on these rejections and all the other inefficiencies, we can reach easily 3.9 million. So that's why we can reach 4 million, and then the rest can be covered, as I'll explain next. Can we move to the next slide, please? The 1.1 million is expected to be covered by the HIV campaign, the 1.1 million campaign which we have launched. Now, these are the key steps. I will not spend a lot of time on this, but except to say that our provincial colleagues have been given key guidance in terms of planning, coordination, all the way to performance monitoring and evaluation. So this is been given, but we're working on it. We haven't gone out to all provinces to talk to them. There haven't been a lot of engagement, but there's currently the HIV meetings that are happening in all provinces. I know this week they're in KZN, so the TB is also included. Next slide, please. So the 1.1 million Closing the Gap campaign for HIV includes TB. I mean, you can, if you look at it this way, if you find 1.1 million people living with HIV, you have to do it viral loads and all that, and you also have an opportunity to do TB NAT. So that's why I'm saying that the 1.1 should be covered through that. So a number of activities are taking place to integrate TB within the HIV program, maternal and child health, and the overall district health services. If this works very, very well, we will get 1.1, maybe even more. And the next slide, please, shows the roles in terms of the campaign. The National Department of Health takes ownership of this, leads the program, develop implementation plans, policies. We're responsible for multimedia campaign, development of materials, podcasts, and various materials have been put in place, and monitoring and evaluation. The NHLS is doing the test. We make sure they get capacity, and they also work with private GPs in areas where there are MOUs in place. Can you move to the next slide, please? Now, the role of provincial and district is really to implement. They're the implementers, they provide a service, they supervise, support, they engage civil society, and the department, the district level support provinces. They do the same, and because facilities are under them. But also looking forward to the next slide, we'll see the multi-sectoral collaboration is very important. We're happy that the accountability framework is in place. We're working with SANAC, and issues around donor partners, all that go through SANAC, civil society. So this is very, very, very important. And I must say that part of the, the issues around response to the executive orders are also coordinated through SANAC, so that SANAC is part of this. They provide funding to a number of NGOs. They are the country coordinating mechanism for global fund funding and all that. So they have all this, they will support us in the running. They also ensure that the multi-sectoral accountability framework is implemented between us and social development, education, various state department, the relations with civil society organization, the private sector, all that is coordinated by the South African National AIDS Council. So the next slide talks about monitoring and evaluation. Number of indicators have been developed to measure the performance of the campaign itself. Some of these have been shared with the 1.1 million campaign for HIV. So we'll be looking at tests done, positivity rates, and looking at incidents and all that. Can you move to the next slide, please? The last one. So in terms of this campaign, we also want to report and recognize performance. We're developing a dashboard. It's already in place, but we still want to modify it a little bit make it better, make it available to provinces, to everyone, so that we can see what's happening with this disseminate. We know we did something similar when we did introduce shorter regimens, and in less than 8 months, we managed to get, for example, everyone getting 6 months regimen for Bridakuli at the People and People L. And we moved very, very fast. We hoping that this will be very helpful. There'll be regular reports. Dashboard will show monthly reports, and we'll be able to analyze the data, identify trends, inform planning, and also find those who will be doing very well and award, the districts that will be doing very, very well. So this, in a nutshell, colleagues, what we're planning around this. Let me stop here, and perhaps we can take the next presentation and have a discussion later. Over to you, Chair. Thank you.
Thank you, Prof. Ndjeka, for that roadmap on the NTB campaign and the plans. So you've provided for us an overview of much of the challenge that lies ahead, that's been made all the more tricky on the backdrop of the reduced resources. But let's not go into questions just yet. I'd like to now invite Professor Farid Abdullah to, I know you don't have a presentation, but you'd like to just address the TB think tank members on your opinion on the road ahead, not only for research, but the TB program and public health in South Africa. Over to you, Prof.
Thanks, Priya, and thanks, Professor Ndjeka, for the opportunity just to make a few brief remarks. And I think the first remark is what's on all of our minds, and I know that Norbert is extremely concerned about this, which is, on the one hand, we have quite an ambitious plan to take the TB control program onto the next level. There's been a remarkable recovery from the COVID period. So the post-COVID recovery has been quite impressive. The big mega trends in the TB program have shown that there has been large impact over the last decade of continually working at the TB program by the Department of Health, by NGOs throughout the country. And that main impact put into numbers is that there's been a 54% decline in incidence over the last decade in TB incidents, and also mortality in terms of crude numbers. Now, a large part of that impact is because of the benefits of antiretroviral treatment on the HIV positive population and its consequent impact on the TB program and the TB incidence program. And the new plan lays out how we can raise the bar to the next level, especially in the HIV negative population, through more testing, better diagnostics, better treatment outcomes. So that's clear on the one hand. On the other hand, we are basically being faced with these rather brutal, precipitous cuts to key parts of the TB program, especially to the large PEPFAR partners who have had a big role in managing the TB HIV co-infection. So organizations investing a lot of time and people in TB preventive therapy, but also in terms of putting people onto treatment, arising out of their HIV diagnosis. That said, there has also been dramatic cuts on TB research. And as you know, our TB scientists in South Africa are at the cutting edge of TB research on all fronts. And there's been quite a big and sudden impact on the TB research program. And I just want to say a few words about that. So the first big dilemma we face is how, with a plan that's, so ambitious, and announcement from the Minister of Health and the department to raise testing, which is like the spearhead indicator there, from between 2.5 and 3 million in the last 12 months to 5 million tests per year. Whilst at the same time, then, we're faced with these budget cuts and there's a resource constraint there. So in addition to that, and maybe this is a little bit in the background, there's also an incredible pipeline of innovation, new tools, new ways of doing things, which many of you in the TB think tank have been driving. And the funding cuts to that research, that R&D, that innovation work, is bound to have a significant impact on our ability to introduce new tools, introduce new ways of doing business for the TB program. So I want to just then dwell a little bit on that. As you all know, with the US funding from the US administration, that generally comes through three main streams. The first was the USAID stream, and in that regard, it has been the most precipitous and brutal of the funding cuts, with more than 22 grants probably affected. The TB think tank secretariat has done a survey which has been published in a letter to the Union Journal, and we estimate that that's probably more than $100 million of funding that's been cut. The two biggest examples are the Accelerate One program, which was primed by Orem in the region of about $47 million for important operational research, which is about how to improve our outcomes, improve that testing that we're all talking about. But another program is the Smart for TB program, which is been led by Johns Hopkins, but with a lot of South African partners. That's about a $170 million grant that was cut precipitously. And, that went quickly, and the grants have been terminated. With CDC, there's been a period of back and forth, and it looks like the majority of CDC grants will continue through to September, the end of the US financial year. And unfortunately, there's no planning that gives any signal for a future beyond September. And most of us have come to the unhappy conclusion that the CDC funding for TB research, will dry out as soon as the current grants come to an end. There's a bit of a debate in the US administration about cuts to TB. So, for instance, the Stop TB program has not been affected. It was kind of fell into that small group of grants that were not cut by the USAID program. But for a country like South Africa, which has got specific executive orders, the signals are that there will not be any continued funding for TB research from the CDC. And then the third group, which many of you are affected by, is the National Institutes of Health. And here it's a much slower process, and there's still a lot of uncertainty. And it seems that these grants will be dealt with on a grant-by-grant basis. And at the MRC, I know that in one of our units, we received one specific termination for a TB grant that was following up for TB incidents in a COVID cohort of patients. There's a program called a VPN 3008 grant. And we've heard now that quite a few grants from the NIH have been terminated, but the majority are still kind of waiting termination letters. Uncertainty is very unsettling because a lot of research managers have this dilemma, which is, should we continue spending as normal, or will we be spending money that we won't be reimbursed for, on the one hand. On the other hand, if you don't spend money and progress the grants, then there'll be under expenditure and poor performance, and that doesn't augur well either. So this big dilemma that fund grant holders are struggling with at the moment. But it's clear that over time the NIH picture will become clearer. On the NIH, you should just also keep in mind that infectious diseases research is likely to be deprioritized in favor of non-communicable disease research. And as I said before, there do not appear to be new funding opportunities being announced, new RFAs being put out. So, that important cyclical continuity of grant application and implementation is being broken. This is, as we reported in our letter, the first time that there's been political interference in NIH research funding, and that does not augur well for any of us or for research generally. So research areas that have been cover everything. Basic science and biomarker, translational research, diagnostics work, a lot of treatment regimen work is being done in South Africa, as we know, especially with MDR TB, shortened regimens for drug susceptible TB, TB preventive therapy, and these are all under threat. And the big new area of research, which is just getting off the ground, is the funding for subclinical TB. And all of this is now under threat. At the MRC, Professor Ndjeka, our president, is taking the lead with senior researchers, scientists, leaders, to look at alternatives. And even though the process is slow, I'm convinced that there is some traction. So we held a funders forum on yesterday, and some funders are willing to come forward to make some replacement funding available, and there are discussions between Professor Ndjeka and his kind of peers with the Health Department and the Treasury, and we'll see, what level of replacement funding can come in. The approach that the MRC has laid out, and it's captured in a Spotlight article, is to take a long-term view on this. So, for instance, there are about 300 PhD students whose PhDs are under threat. And if those are all kind of fall to the wayside, then we're putting really the next generation of scientists at risk. And that has a long-term impact, so sight should be kept of that. There's also a lot of young researchers with small NIH grants that should be prioritized in the alternative search for funding, and then some large research groups will need some bridge funding. So there's some thought being given to what is practical, what is practicable, what is doable, and what's possible. And I want to end my comments by saying that it's really important that we maintain our fidelity to our ethical obligations. So where we have a trial with participants in the trial, we need to make sure that ethics committees are aware of any changes being made to the protocol, that participants who are in the program are followed up, and that any closeout procedures are done meticulously and according to sound ethical principles. So with that, I'll just thank you for the opportunity for raising some of these issues around TB research funding. Thanks, Priya. Back to you.
Thanks, Professor Abdullah. And, I'm just thinking back the last time we were in this kind of chaos in public health. It was around, COVID-19. And people are even saying that perhaps, these funding cuts and the immediate kind of termination and stop of activities is leaving us, in a much worse position than COVID did. But I want to now, unless either profs have anything further to say, just move on to our consolidated Q&A session, if that's fine. And what we've tried to do was take all the questions that were provided by the TB think tank members, combine them in specific themes to be able to bring out, some of the core questions that were being asked. So the first one has really, the first section is around funding and sustainable funding. So beyond traditional donor funding, what innovative financing mechanisms like public-private partnerships, domestic resource mobilizations is the National Department of Health exploring to fill the gap left by the US government terminations? So I'm going to pose that first to Prof. Ndjeka, and then Professor Abdullah, if you have anything to add, please feel free.
Okay, thank you so much, Priya. So in terms of the funding, maybe what I need to say is that the National Department of Health has taken stock of the damage, if I can call it that way. We've been really trying to understand what is going on, but you'll agree with me that the challenge with that is that a lot of the communication did not come directly to us, and it's not coming directly to us. We get to hear this from other colleagues who are themselves in trouble with all this, and is not even sure whether everybody is disclosing what is happening. It looks like some people are just fed up or maybe depressed, they're quiet, but we're trying to understand what is going on. And there've been consultation with the National Treasury, and the Parliament is constantly asking questions, same question you're asking now in terms of what are we doing. We've spoken to National Treasury, we've spoken to all the stakeholders, and the meetings are still ongoing. Now, some of the ideas include what the DG explained some weeks ago, having a sort of a solidarity fund, which is funded by government and private sector, and then it is managed. That is possible, seeing that we know exactly how many people have lost jobs, where are they, so that has been established. How much money is needed, that is also established. So if you have sort of a solidarity fund, that could work, but you need to get people, donors. Government money alone is not enough. There have been meetings with, for example, the Mineral Council in South Africa and various other donors. So Minister has been engaging. But at this stage, I cannot say that I cannot tell you who's volunteered how much for this. So the talks are ongoing. The good thing is we have an idea in terms of what is going on. And we're also happy that MRC and other researchers are also trying to get alternative funding and all that. So this is what is happening. Now, if you come up with something that is controlled in the country by various South African structures, that is more likely to be sustainable, because then you have private sector and government put the money together and agree on how to manage. So for me, I think that's probably where we're going. As to whether it will materialize, I'm not sure. We got additional funding, Minister announced the creation of 1,650 posts. That money is already, but 1,650 is not enough. We know that we probably need 15,000 healthcare workers back. But what Treasury has done to grant this additional funding, I think is a step in the right direction, and we hoping that there will be more of such interventions. So there is work happening, but I can't tell you exactly what is being agreed upon. It's still work in progress. In the meantime, we're trying to make sure that the services are given to the patient. I think that's what really government is trying to do. At least get a nurse see a patient, get a doctor see a patient, provide treatment. We know that most of these funds, I mean, our drugs have been purchased by domestic fund and global fund. We not use USG money to buy TB drugs. We have domestic plus global funds to buy, and this is still secured. I know that there'll be problems maybe in future with all the donors. It is possible. I'm not saying it will happen, but from the look of things, we may have challenges. But at this point in time, we have the money. Global Fund is still providing the money. We're not too sure moving forward, but it's still there. Why I'm saying this is because I know that US contribute to Global Fund as well. So it's logical they could say our contribution should not go to South Africa. That is a possibility, and everybody knows about it. So we're going to be thinking then more in terms of how do we get more domestic funding into the healthcare. And it's a pity that the National Health Insurance is not really taking off, because I think NHI would have been big in terms of solution for this kind of crisis. You know, I mean, most people agree that there's a lot of money in the country, but some of the money may not be properly allocated. So effort is being done also to try and locate this money, find the address where the money is that are wrongly located to try and bring. So I know it will take a couple of months, but maybe even years, but I think that's really the direction that we need to be taking. I don't know whether I've answered your question or I've confused you, but let me end here. Thank you.
No, and I mean, it was really around innovative financing, but even Prof. Abdullah had indicated that the CDC funding, which is safe now, in 5 months' time, might not be there. And should we also be looking at things proactively? The survey we did, the numbers we tried as the TB think tank to be able to kind of crunch all those numbers together to determine the impact. It was done after the terminations and the stop work order was already received. But now, while we still have an opportunity, to gather information from the CDC counterparts, understand very clearly about the contribution. I heard it's about 1/3 of the Global Fund contribution that's coming from the US government, or just around 1/3. Is there anything that we can do, to kind of preempt and really understand the full magnitude of the potential of this?
Yeah, maybe let me quickly come down for it. There's a lot of ideas on that, but the issues around innovative financing, the reason why I didn't touch on when I was speaking earlier on is because we have a lot of ideas that have not managed to fly. They've not been taken into consideration. And I think now we have an opportunity to get those ideas from the drawers and put on the table and start talking again. We had a discussion some years ago when we brought in the 6 months regimen to say, why don't we have social bond impact? I don't know, is it SBI or social impact? I don't know exactly. I'm not very financial, but I know the ideas that I knew. We've been talking about it, but very difficult. It has been very difficult to get the donors agree to do. I give one. I think Farid can give you more, but they've been good ideas. But for some reasons, just like when we say, can we support people socially so they don't come with TB? Such ideas are there. Maybe now is the time that we take them out of drawers and repackage them and start, maybe because we're not very efficient in how we spend the money. The money is a lot, but the allocation of the fund, good ideas don't get funded the way some of these other ideas are done. But let me stop here and allow Farid to carry on. Thanks.
Yeah. Professor Abdullah?
Thanks, Norbert. You've kind of set me off now. But so a few quick things. One is that we should never, ever again be so dependent on a single donor for TB services and for TB research. So it's important that we think and diversify our sources of funding and spread our risk. If we don't learn that lesson from what's happened now, that would be a sad day. But as Prof. Ndjeka, has mentioned, there are innovative funding mechanisms. So the first is that we have to think economically about our TB research. At the moment, our research is for new knowledge, for publications, for new tools, so that we can have new policies for better implementation. But there also has to be an understanding that there's an economic value chain. So research should lead to new technologies, new tools. New tools should lead to local production and manufacturing. And, there needs to be an economy there, and the government needs to commit to market share for tools developed locally. And the overall benefit should be better tools at a lower cost, and that gives you the right economic incentives to invest in research. European countries invest a lot in research because they see it as an economic endeavor. We need to change our mindset. But in addition to that, we also need to look at public-private partnerships. Prof. Ndjeka and I are working on something called a social impact bond, where we will bring private investors, local investors into the provision of a TB service, which is linked then to improved performance and better outcomes for that program. We don't have time to do it. Maybe we can do a seminar on the impact bond, Norbert, but there are those sorts of innovative ways of dealing with it. But the bottom line is that, we also don't commit enough funding for TB research from our own resources. And if there was one area of medical research where we are world leaders across most of the research domain, it's got to be in TB research. And yet, we're not being able to convince the Treasury decision makers that there need to be more investment. So we've got a lot of work cut out. And as Prof. Ndjeka mentioned, we also have a lot of resources coming in, and we need to coordinate that, tightly manage it so that we can, extract the full value of the funding we already have. One last thing is, if there's a decline of incidence of 50%, why are we not monetizing that? That's not led to any decline in costs. And so we need to look at our cost structure and, how those resources that have been allocated should be then, employed in ways which lead to quality improvements in the program and better outcomes. And that's a big, big conversation that, we really do need to get to the bottom of. But I'll stop there. Thanks.
Thank you. Thank you for that. I want to try and get to as many questions as possible, but I also know we have, very limited time. I want to move to one which sounds extremely frustrated, so I'm kind of preempting you on that one. And the question is, what health system strengthening mechanisms are being prioritized to address the service delivery and the infrastructure gaps in TB care because of the reduced funding? And it says it would appear as if the Department of Health is continuing with business as usual when more than 15,000 healthcare workers are no longer supporting TB HIV activities and things are anything but business as usual. So, just to get a sense, it's as if, there is no message out there to the existing healthcare workers that this is going to be a struggle and it's going to be difficult. And we need to kind of dig deep and, work together with the purpose in mind. Unless we're missing it, but it seems like everything is just, moving as usual. So maybe you can help us understand, maybe behind the scenes, what are the health system strengthening mechanisms that are being prioritized, particularly around the service delivery gaps.
Yeah, thanks a lot. This is a very, very important question. I must say, whoever asked the question has made a right observation. The government officials, including myself, have not shown that when in a crisis. I agree with you. But I think it's part of the response itself. When I was a young man, I was taught that a lion doesn't cry. I think that's probably this personally what I've observed, but it doesn't mean that we do not see the trouble we're in. So the ASIRAS problem, and I agree with you that this crisis is worse than the COVID one. So there've been a lot of thinking, but very little communication, but definitely meetings earlier on before we started this conversation. I'm saying I'm surviving with all these meetings, thinking with Treasury, thinking with this one, thinking with everybody, which is good. Although we don't really have a solution on the table to say this is the plan, let's go with this. But I believe that from these various interactions, we're going to see better results, because when we talk to provincial colleagues, you can see most of the time that they're also concerned. And the one positive things I've noted is that everybody, including the most junior colleagues, understand that we all have to work towards a solution, and that's really what is very good here. Interaction with WHO has also changed. We talk about key issues that we should be talking about more around technical assistance and all that. We know that funding has decreased. I know a lot of colleagues, like in the various platforms I manage, who are saying maybe we should stop meeting face-to-face, we should do more of virtual. So there are a lot of ideas around that, but I wouldn't say there is a plan at this stage. We're moving towards a plan. I believe within the next few months, we should be able to say this is the plan, but the awareness part is working very well. And we're going to come up with a plan when time allows. I think at this stage, there are a lot of logistics that have to be addressed urgently, which we're trying to do. Imagine, for example, CCMDD. you got the drugs, but you lose all the personnel who have to assist you with distribution of ARVs and all that. So we've had a lot of issues, but I must also say there've been more damage towards HIV than TB, and we're very sympathetic with that. So we don't just look at TB, also look at HIV. I get worried about everything, TB, HIV, all the other things. So there aren't plans yet, but there is conversation, and in the coming weeks or months, we should be able to come up through our minister with something that we put out in the public. Thanks.
Thanks.
Thanks. A quick reflection from me. I think the first thing to do is to acknowledge our problems, and it's really important that no one walks away from any discussion on these funding cuts with the idea that it's business as usual. And that was one of the reasons why the think tank has put on this webinar, and that's the first thing we should say. And so I'm appreciative that Norbert is starting off with that point to say, actually, there is a crisis, and it's affecting all of us. The second thing is that we shouldn't take a defeatist attitude either. And there's a lot of circling going on, and I can't help thinking that the think tank really can have a role here, because we could step in and offer some practical solutions about how to tighten up things and offer practical solutions. We know that Prof. Ndjeka and the department have always been open to practical suggestions. So I think it might be worth our while to, in the same way that we supported the department to do the strategy, to do the Global Fund application, to do a lot of things. I can't help thinking that that's something we could actually do, is to make some good practical suggestions of how to address the crisis. We've started helping by describing the problems, identifying the funding cuts, which was used by the department, but I'm sure we can do more. There's a lot to be done, but the first point is to acknowledge that taking 15,000 health workers out of the system is a massive problem, and all the other things that go with it. Thanks.
Thanks to both the professors. I know there's quite a number of, the biggest theme was around funding, but I'm going to move on from that one. And the next question, I think, is also, critically important, because it's with the declining resources that we now see ourselves with. How is the Department of Health prioritizing between maintaining existing services and scaling up innovations like new diagnostics, the new pediatric TB guidelines that we're rolling out, and other innovative approaches that we're advocating for? So how is it balancing or prioritizing between maintaining and scaling up innovations in the face of declining resources?
For Farid to go first, or if you want me to.
Go ahead, Norbert.
All right. Yeah. So I think that's really a very difficult one. Balancing. I think at this stage, what we're really doing is try to understand what is going on, try to maintain the basic services. Maybe in next 3 months, you can, we could be looking at that. I think at this stage, we're really trying to do, switch off the tap or the fire. I don't know. It is still, it's tough. I wouldn't say much on that. I don't know what you think, Farid.
Yeah, I agree with you. I think that that it's unrealistic to think that new programs or additions, new tools kind of can be added under the current circumstances. That would be like pretending that we're not in a crisis situation that we are in. And I think there's one exception to that, which is if there's a new tool, which then is also cost saving. Those are the sorts of things that we shouldn't hesitate to do, because they give you more services with less cost, and there might be some examples of that that we can talk about. But I honestly think that honesty is the best policy here. To think that we can be doing new programs and extensions of things would be quite unrealistic at this stage.
Kind of, linked to what you're talking about, cost savings, I see there's another question around, should we be looking at plans to fast track cost-effective solutions? And I think what they're referring to here is that a large number of data captures, for example, have been removed from the health sector, and things where nurses can capture directly bits of information on apps that collect information, and other innovative technologies like using telehealth and things like that. Are we exploring those kinds of cost-effective, more innovative solutions to offset the reduced human resources?
Yeah, I think that is being explored, although I would caution, we before we got data capturers, we had a lot of issues. And that's when there was this project, this famous project 3500 came up for data capturers. So if we're going to go back that route, we got to be careful. We need to identify areas where this can be done. But I wouldn't take it, I wouldn't think that replacing these cadres with nursing professionals is a good idea. It wouldn't work. I don't know what to think for it.
Yeah, I'm not sure that the nurses would be the best replacement, but there must be alternatives which capture the same principle. So sharing that, also sharing data captures across programs. There are lots of opportunities for that. Sure. Integration has to be a big part of the new agenda.
Okay, thanks for that. So there's another question around keeping TB high on the national agenda, and what is the NTP's strategy to keep TB high on the national agenda amid the competing health priorities like HIV and like NHI?
Yeah, so thanks a lot. That's a very important question. We're looking forward to the work with SANAC and the various committees. Civil society helps a lot. Many people don't know this, but civil society, we have a vibrant civil society in South Africa. They really help a lot with what they put in the public. Within the department, we made effort to put a number of adverts on TV. We put in billboards. We continue to do that. We're working on podcasts and all that. Thank you to Global Fund that gave us some money last year and early this year, which has allowed this work. We are hoping that in future there will be also increase in terms of domestic funding to talk to the people of South Africa to continue, working with SANAC, because they also need funding to be doing this. The My Story app that we developed, the civil society has been working in that. So a lot of work happening, but I think with civil society, because they're louder, their voice is louder than government, we're not trained to communicate. So we really look forward to the journalists. We have a company that works for our events and all that, and the other one for communication. So all these are the resources that we're using to try and improve. And I like to believe that we've improved, although we're not yet where we want to be, but there is definitely some improvement. Yeah.
Okay, thanks. And I think this one is for you, Prof. Abdullah. With research funding at risk, how will South Africa protect critical TB trials that are already underway? And I know you kind of touched on it, but perhaps you want to just elaborate a little bit more.
Yeah, so as I said before, the SAMRC is very, very engaged with trying to find alternative funding for critical areas and clinical trials, at least the continuation, the ethical continuation of them, is one area of importance. I know that the leadership of the MRC is engaged with the Department of Health, the Department of Science and Innovation, as well as Treasury, and importantly with philanthropies and other donor agencies to see if replacement funding can be sourced. I think it's there's a lot of complexity when it comes to this, because just getting extra money whilst it's difficult on the one hand, how do you distribute those funds? How do you prioritize projects which should be funded? Those are issues that we are grappling with. But the most important thing is that no one is able to replace a grant like, say, Accelerate One, which is $47 million. I mean, I think we must be realistic about what we can achieve with this. But I know that the conversations with important institutions like the Gates Foundation, the Wellcome Trust, and our bosses will be kind of informing the public about that. All I can say is that there's a lot going on, to make sure that TB research continues to be funded from domestic as well as other resources. So that's all I can say at this stage. Maybe one more thing, which is the think tank has put out a survey for anyone, for all projects which have been cut, and the MRC is also collecting a database of all these projects. So please, if your project is cut, make sure that you are communicating with the MRC as well as the think tank, so that at least we have a good live database on what funding is being lost, especially now when NIH grants are going to start being terminated. It's really important that we need to know that. I think we have probably the majority of grants on the database already, and some estimates of what is being invested. I can tell you that we estimate about $150 million a year for NIH-funded research in South Africa. But it's important to get it all in. Just to say that, and if you don't know who to send it to, then please send it to the think tank people who are running this webinar. Thanks.
Thanks, Professor. I didn't realize, but we are over time. And if our TB think tank members can just indulge us, as well as our panelists, for an additional 10 more minutes while we just look to answer, the last few questions, and then your final thoughts to hopefully leave us with something positive, because I know a lot of this discussion is really, to put it mildly, depressing. And I just want to, and I know that we said no more questions about funding, but I think this one's crucial because it links both with, the NTB campaign, Prof. Ndjeka, and that's really, the funding for those tests, the 5 million tests, are coming both from domestic funding as well as from Global Fund. There's already signals that Global Fund or the US government is pulling out of Global Fund. And are there any contingency plans to fund the TB testing, particularly if the Global Fund money for the next round is scaled back?
Okay, no, thanks a lot. I think the issue around the funding for NTB campaign, like I indicated, at this stage, we have indication that funding is enough, but should there be trouble in future, we'll deal with that. Let me just give something here, just to put the whole thing in context. We have 23 billion rands a year conditional grant in South Africa. TB gets 1 billion out of that 23 billion, right? So obviously, if you break down the rest, you'll see there are a lot of things there, like condoms and this and that. We really need to then begin to say, can we find a little bit, maybe 200 million or 100? No, maybe just what, few millions from these 22 billion left. It is possible. I also indicated that the 1.1 out of the 5 million will be covered by the HIV, which is on the other part of the conditional grant. So these are some of the issue, the context that really provinces should know. But this 23 billion HIV conditional grant does not include provincial equitable share. All provinces have money for TB every year. They have equitable share for TB, for HIV. So your conditional grant is additional to what provinces already have. There have been two problems with the TB program. I've been in this program for many, many years. I worked in the public sector in South Africa for what, 80-something years. Two problems. Number one, retaining money back to government from TB program because a donor has given that thing. We need to stop that in South Africa with immediate. I've been saying this, but I think I should now start saying this in a platform like this, because even when I was a medical officer, I remember we just save the money, you get it funded. You budget training, you don't use it, you get it funded by the farmer, you're happy. What does Treasury do? They cut it following year. So your budget keeps going down, 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 down. So we must stop that. Number two, the question of using conditional grant in a province for personnel, which must be covered by equitable share. So as I said, we need to be more efficient and do the right things. If you get a additional budget in the form of conditional grant, do not remove TB allocation from your equitable share because there's Global Fund money, because there is conditional grant. So this is the type of conversation that we're having with colleagues who run programs. We've got to do things right. And you can see we can't rely too much on donor funding for everything, particularly if there is some money allocated for these things for equitable share in the country. We've got these billions in the conditional grant. A little bit of it will cover TB, but if we do the right things, we'll be okay. If people are going to post money to wrong addresses, then we're going to struggle a little bit. I hope this is very clear. We can have another session one day to explain, how we fund services, but, Global Fund is additional. Conditional Fund grant is additional to provincial equitable share. Now, when you remove the equitable share, then you can say so, and then we can have another conversation. You must first tell us, why do you remove equitable share TB, and now you want to complain you don't have enough, because this other money is additional. It was never meant to replace our budget. Yeah.
Yeah, so it seems like there is a significant amount of funds that we could be utilizing, but we're not managing that very effectively. Final thoughts?
Yeah, final thought, just to pick up on what Norbert said. He was very diplomatic. I'll be less diplomatic. There is a lot of inefficiency and wastage in the provincial health departments. And unless we address that, we are not addressing the fundamental underlying problem here. And now we are all relying on donor funding and conditional grant funding to run the TB program. But the core funding is in the provincial budgets. And whilst there has been a lot of doom and gloom, actually the biggest news on financing in the last 2 weeks has been the addition of 28 billion rand to the provincial budgets. And, without that additional funding from the Treasury, I think the provinces would have been in deep trouble. But it is a significant injection of funds under these austerity times. And, that funding has to be used effectively. And I think we all need to build whatever needs to be done to make sure that those funds are used efficiently. And that's the starting point to rebuild and decrease our dependency. And with that, Priya, I do have another meeting that started at 2, so I'll sign off and thank you all.
Thank you so much, Prof.
Okay.
Prof. Ndjeka, just some final thoughts from you before we end our session, and thank you for staying this long.
Yeah, thanks. No, maybe I need just to say that one of the tools that we use to measure our response in terms of drug-resistant TB, the EDR web, has received some attention. So the UNITAID is promised some funds, as well as the Gates Foundation. So we hoping that in the next few days we'll have it signed off, and then continue to work maybe for a couple of months. We have spoken to Global Fund. We're also waiting for their response. So if we get these two plus another organization, we'll be able to see how we move forward with. My final thoughts are that for TB, we got to be more effective, more cost effective. Let's use all these modeling data we have, and let's allow science to speak so that we do what is really most cost effective. And if we do that, I believe with less money, we can do more. It is possible, but we just need to agree, have one conversation, and identify what's our priorities in terms of human resources, in terms of activities. We should be able to do more, but this is going to be very difficult, very, very difficult for all of us. It doesn't matter at what level you are. And I look forward to ideas from the TB think tank, particularly because that's your job, to think on behalf of government. I look forward. At this stage, we don't have a plan on the table. We need to continue thinking until we come up with solid plans that will have been will have come from everyone, from the people on the ground. I think that would be, for me, that's the sustainability we need. Best ideas to be more cost effective. So our plans need to be probably refined. Reprioritization is critical. It's a pity we see this just when a year after or two after our strategic plan, but I believe we will get that support from TB think tank. Thank you.
Thanks, Prof. Ndjeka. And just to indicate that, clearly this U.S. government funding termination has tested our resolve, but it's also underscored the strength of our collective mission, we can see that there is potential opportunities to think, think about or anticipate some of the additional challenges that are coming our way after September and plan now for them, but also opportunities within the existing environment to be more efficient, to be more effective. And then I just want to use the last few minutes to just indicate that, the Secretariat over the past few months has also been working deliberately to ensure that, we are looking at our members, we are trying to understand their challenges better. We've done some stop work impact modeling to attempt to quantify the disruptions and guide some of the mitigation strategies. We've launched, as they mentioned, the surveys to gather critical data on the funding cuts, published our findings in the International Journal of TB and Lung Disease, sounding the alarm on the consequences of the disruption to TB services. We've also presented to the NTP cluster at their monthly provincial meetings the same impact analysis. We've tried to increase the frequency of our EXCO meetings so we can keep pace with this rapidly evolving situation so that we can take, some decisive action. 1 minute it was a pause, then there were, case after case, lawsuit after lawsuit, and it was just constantly evolving. We also issued, on social media, urging community members and our TB think tank members to try and remain steadfast amidst this uncertainty, and hosting webinars like this, these special webinars, so that we can continue to communicate. And really that's what the TB think tank exists for, as Prof. Ndjeka has indicated, to lead the evidence, to advocate with clarity, to support each other with purpose. And today's discussion was just another step in that direction. So with that, I'd like to thank you all for attending. Thank you to our panelists and Prof. Ndjeka for your time, and I wish you all the best.
Thank you and goodbye. Thank you.
Bye.